to talk about this topic. So my name's Aneal. I'm a pediatrician and medical geneticist. I think I got something pop up and I gotta just, it says, it's that message, it's being recorded, but I can't get it off my screen. Hang on, let's try this. Okay, go this way. So my community clinic is called Magic Clinic for Metabolics and Genetics in Canada. Clinics in Calgary and Vancouver, although our study site is only in Calgary. So it's just something to keep in mind. And I have a number of disclosures, which are listed above. I won't list them all. I sit on a number of committees. I have grants, and I also, especially for this trial, do have a grant for the Sangamo gene therapy study. This is not a recruitment session, though. This is an information session about gene therapies. Best to discuss with your doctor whether it's the right thing for you, and ask any questions you have. So we know in Fabry disease, the basic finding is the alpha-galactosidase enzyme is not working properly, and it's due to a change in the DNA sequence of the GLA gene. So up to this time, only one gene has ever been attributed to cause Fabry disease, which is the alpha-galactosidase gene, and only one enzyme resulting from it. And based on that, of course, many years ago, treatment was started with enzyme replacement therapy. There's two products in Canada that are approved: agalsidase alpha, agalsidase beta. There's also an oral chaperone therapy that's approved called migalastat. And what migalastat does is it helps protect that enzyme as it moves from one part of the cell to the other, so that it ends up in the lysosome. Certain people with certain DNA variants will respond to migalastat, and those can be checked on an amenability site. So those are the standards of care. The thing with standard of care, though, is still leaves, it's not a cure. And here I have a normal heart biopsy from a textbook on the left showing the pink fibers of the heart. They're arranged. You can imagine the heart is contracting like this. And so the fibers have to move in unison. And they're arranged like that. And in the middle, you will see a biopsy from a Fabry heart where you can see that that organization is lost. And how is that heart supposed to contract properly? I don't know if the arrow thing is working, but I'll just highlight it through. Do you see an arrow when this pops up? No, me neither. There's some zoom setting I guess I didn't get, but that's okay. We have colors here which will work. But so inside these heart cells, which are in red, you will find sort of bubbles, which are vacuolar changes, and that shows, you know, accumulation of substances that damage the heart cell, and it's no longer functioning as muscle. And you can see those white accumulations throughout the heart muscle. Particularly concerning is the blue staining, which is fibrosis of the heart. And that's one of the things we find on MRI. And it's one of the reasons we do a lot of MRIs in Calgary and in other centers. Because that's irreversible when that scarring happens. And so we're always looking to see whether the scarring has occurred and not wait for it to progress before starting any form of therapy. But this patient was on enzyme replacement for 10 years, and you can still see that there's significant injury to the heart. So you know, and we can debate how much enzyme gets penetration and how much the oral chaperone gets penetration, but you can see replacing the enzyme or improving the enzyme, whichever form you choose, whether it's enzyme replacement therapy or gene therapy, is only going to help in certain ways. And having more enzyme around is not the only solution. So So there's a lot left for us to still learn about Fabry disease rather than just replace the enzyme through whatever means you're choosing. But we do know that when people are on enzyme replacement therapy, which is the box on the left, you get a brief burst of enzyme in your bloodstream. But in between doses, you're basically back down to your wild type activity, which may be 1% or less in some cases. Most of the enzyme is gone from the circulation in 1 to 2 days. So that means that for most of the time, it's back down to where it was. Nevertheless, enzyme replacement therapy has been shown to be a significant advance in treating Fabry disease. I don't want people to get the wrong idea. And even with those intermittent doses, it seems to be having a beneficial effect, as well as increasing enzyme levels through chaperone therapy. So the concept behind gene therapy is, though, can we try to approach a more natural level of increase in enzyme activity where it's 24/7 expression, maybe doesn't hit the peaks that you would get with an enzyme infusion, but it's more consistent. And so that's the concept behind what gene therapy aims to do, is just have more stable enzyme levels. But its main purpose still is to make more enzyme, and that's something we need to be mindful of. This is a paper we recently put out from Alberta data with our colleagues, Dr. Udit and others in Edmonton, to show, how we use MRI to look at outcomes in Fabry disease. And the graphs may be a little hard to see, but if you look at the top left graph, you can see the number of events. So the higher number of events means you're higher up on the graph of cardiac related events. And you can see if you have LVH present, which is left ventricular hypertrophy, you tend to have more heart events than when it's absent. And that's now over a period of 7 years it's measuring. So your event rate will hit 50%, when LVH is present over 6 years of measuring it. Stay under 50% when LVH is absent. And the scarring I pointed out on the MRI is the box on the right top, that's B. When scarring is present, late gadolinium enhancement, that's what LGE stands for on the MRI, then you have more cardiac events when the scarring is already taking place. But there's other things we look at too. So if you look at box C, you can see controlling blood pressure is important because you have more cardiac events. If the blood pressure is high, you have hypertension versus no hypertension. Or when your lipids are high, which is box D, versus no dyslipidemia. So these things indicate that there's a component of the Fabry disease itself, right, which causes heart disease, left ventricular hypertrophy, or scarring, but there's also components that aren't directly related to Fabry disease, such as hypertension, dyslipidemia, which also contribute to cardiac events. So it's a multifaceted disease, it's a complex disease, and it's important to understand that just correcting one enzyme or correcting one gene is not going to deal with all aspects of a complex disease. There are unmet medical needs in Fabry disease despite the treatments. The approved agents you need to take for the rest of your life, whether it's enzyme or oral therapies. And some of the symptoms don't seem to respond that well to many of the existing therapies, such as pain. Fabry patients can have severe pain. Stroke hasn't been shown to respond that well to any of the treatments. The gastrointestinal upset also can be persistent, but some people on oral therapies have been shown to have perhaps more of a response than they traditionally did in the past. Certainly in my clinic, we've seen that. But there's still incomplete treatment of the heart and kidney disease. The heart and kidney disease are two components of the disease that do respond with existing therapies, but it's incomplete. And most of these disease problems are still irreversible. Anyone who is a Fabry patient or manages Fabry patients in no way, shape, or form thinks that we have a cure sitting there right now, and there still is a lot of work to do to try to improve the lives of these patients. When it comes to gene therapy, the purpose of the gene therapy is to put a working copy of the gene so that the enzyme is made basically all the time. And there's two different approaches. The one on the left is called the lentiviral approach. In the lentiviral approach, we take out stem cells and put the gene therapy in the stem cells and put the stem cells back into the patient. So what we're giving the patient are actually stem cells that have the vector in them, but not the vector directly. And that was the basis for the first set of experiments with the FACS trial, where we removed stem cells. They got a conditioning regimen, and we put the stem cells with the vector back in there so that it would continue to make enzyme. There's many newer studies that have come out, and you probably have heard about them. We can talk about them. There was one that was recently discontinued, which is the free line therapy. The Sangamo trial is still ongoing, but I know there's another one, and I can't mention it yet because it hasn't started, where they also have a different type of AAV vector. And the AAV vectors are really where the gene therapy product is inside the vector, and we directly inject that product into the patient. So you can have some immunogenicity, because if you've seen the remnant of the virus from which the vector is made, then you might already have antibodies. So we have to screen patients for antibodies to make sure they can get the vector. Sometimes you might have to use immune suppression because the vector tends to go to the liver, and you may have to suppress liver inflammation temporarily as part of the treatment. And you can't really redose, and you're basically targeting the liver. So if you think about Fabry disease, the liver is hardly ever an organ that suffers from Fabry disease. It's the heart, the kidney, the vascular system, the brain, so on. So if you use an AAV vector for gene therapy for Fabry disease, you're basically using the liver to make enzyme, hope the enzyme then gets into the bloodstream and that other cells pick it up. With the lentiviral gene therapy, you're hoping the bone marrow is where the enzyme is made and it circulates around and it gets picked up. So they're two different approaches, but with the same result of the body constantly making its own enzyme activity. So with the in vivo approach, like I said, it's a direct injection. The injection time can vary. Sometimes it's about an hour or more, depending on the dose. And it actually is an approved way to treat certain types of hemophilia with certain products. And estimate now is probably more than 2,000 people around the world have been treated with some form of AAV type gene therapy. The one we did in the FACS trial was the ex vivo lentiviral gene therapy, which was really the first one that came out and was used for immune deficiencies such as severe combined immunodeficiency. They didn't use lentiviral for that, but they basically harvested stem cells, which they then modified using the gene therapy. So with the ex vivo, which is the one on the right, where we give the stem cells back, those stem cells are permanently modified with the gene therapy vector. It integrates with the DNA. With the in vivo, the AAV gene therapy, it doesn't integrate with the DNA. It sits by itself like an extra guest at the dinner table. Like an extra guest, it will consume things and make contributions to the table, but it doesn't integrate. And it's possible that its effect may be lost with time because it's not integrated and not duplicating when the body cells duplicate. So there are pros and cons to the different approaches, but there's no conditioning regimen with the AAV vector therapy. There's no chemotherapy that needs to be given. So this is our first patient with Fabry disease gene therapy. I think he's on the webinar tonight, and that was a momentous day. And I'm glad to see that things are still stable and well. But you can see this was done in a hospital. It was done using the stem cells. Stem cells would have been harvested sometime before had the gene therapy vector put in them and then injected. And the paper came out, which should be available online. I might have a paywall, but I think it's old enough now that maybe that paywall is gone. But where we presented that data, and I won't talk too much about that data right now, except to say that, you know, in the 5 people treated in the 3 different centers, Calgary, Toronto, and Halifax, all of the patients so far remain stable and are making some enzyme at various amounts, but they're making some enzyme. You may have heard that there was a second part of the study, which was done outside Canada, where people didn't respond as well. I don't have all the details around that, but I think for the Canadian patients, we've seen that they all have responded to some degree. So somehow the Canadian patients were a little different in terms of the response. Okay. So anyhow, for that form of gene therapy, the main outcome measure was enzyme production. And so we used Fabry males because in Fabry females, enzyme levels between unaffected and affected females have a large overlap, and it's hard to know that you actually increased the enzyme level. But for many of these AAV trials, both males and females are being recruited. So we'll talk a little bit about this study. ST920 is the name. It's using an AAV serotype 2 and 6 with a direct intravenous injection. So it's an in vivo gene therapy. If you're curious about which sites are involved, you can go to the clinicaltrials.gov website, type in ST920, and it will list, I think there's 21 sites listed right now. And it's a global study, so it's 21 centers around the world in many different areas. They want to recruit up to 150 patients, both male and female above 18 years of age, who are currently on enzyme therapy. You'll see there are different subgroups as well, which makes it a little challenging because sometimes patients may call and they want to be in the next enrollment phase, but we may be told that there's a different enrollment phase happening at that particular time. So you'd have to check with your study center to see what enrollment phase they're in. And one of the main objectives is to measure changes in renal function over time by calculating the eGFR. But there are other observational endpoints too, including how much enzyme is made and lyso-Gb3 and so on. So basically, you have different cohorts, and we won't go through them all because it gets to be quite a bit of alphabet soup. So they go up to cohort 3E. You have renal, you have female cohort, cardiac, and then sometimes they're subdivided: females with kidney disease, females without kidney disease, people on enzyme therapy, so on, those who are antibody negative or antibody positive. So that's a little complex to understand. So it's always best to check with the center that you're connected to see what cohort is being enrolled. But it's for adults, so 18 years or above. And you get the DNA testing done again because it's just part of a standard protocol now to include somebody with a trial like this. The sponsors have to verify the genetic change. And patients right now, for example, I know one of the recruitment phases is with people who are on ERT. The renal cohort, you have the GFR for the renal cohort there. So there's some enrollment going on with that as well. And of course, it's voluntary and you don't have to participate. Things to watch for is if somebody's been on Galafold, they have to stop treatment within 12 days of day 1. We don't really recommend somebody who's on a standard therapy to enter a research trial. So it's something that you need to be aware of. It's not going to be a recommendation for many of the trial sites that you do that. History of renal dialysis or transplantation, heart classification 3 or 4, heart failure, which means people with really active heart failure, or anybody who's had any of these viral infections before, history of liver disease or fatty accumulation in the liver called steatohepatitis or cirrhosis, and various other liver conditions. Also, you can't be on another study at the time. You can't have been previously dosed with a gene therapy product. And of course, you have to comply with the study protocol. So this was from a newsletter the sites get some while ago, just indicating how different cohorts are being recruited around the world. So you can see female cohort, renal cohort, cardiac. Those have positive antibody to the enzyme and negative antibody. If you have positive antibody to the vector, then you don't get recruited. So that's not on the list here because it's an exclusion criteria. And so you have various different enrollments and then the number of slots available. Total number of people screened at that particular time was 29, and subjects rolled over to the long-term study were 6. And you can see the different sites that have been started up in different parts of the world. So most of the sites right now are in the US, with some in the UK, and so on and so forth. So it's still an ongoing study. It's underway, but enrollment is taking place. This is public data that's available. Of course, wouldn't be talking about any confidential data. So this is taken from the website, and it's just to show you an example of what's being looked at. So on the top left, you have cohort 1, where they would be classical males, and you see low enzyme activity there at the bottom left of 0 on the graph. And then you can see in some of the subjects, you get quite a significant increase in enzyme activity, and some not so much. And then the red star indicates in some patients where ERT was withdrawn. And so you have cohort 2, cohort 3, 4, all showing sort of the same effect, that you do get a variable increase in enzyme activity over the number of days that have been measured on these graphs. Some of the graphs are now going to a year or more. So it's showing a response in some of the patients. Not all the patients are graphed here. I don't have all the data, of course, in a study like this. So selected patients are being shown. So what has been observed in a press release from Sangamo is that you do get sustained elevated expression in 13 patients over 2 years. That's been the longest cutoff because there were different components of the study previously. And those patients that went through dose escalation went off ERT. So that's encouraging. And they also had an improvement in their general health scores. Some of them had a reduction in their lyso-Gb3 levels, and then they give you a range of 2-fold 34 mean normal increase in enzyme activity in the patient, so quite a range. They state that the product was well tolerated and no treatment associated as adverse events higher than grade 1, with 1 fever that was grade 2. So that's sort of a summary of what's the experience been. So of course, the presentation like this, an hour is too long. So I thought we would stop there and let you ask questions and just have more of a chat about things. Just wanting to thank the group here for all the work that they do to bring these studies forward.
And Dr. Khan, thank you for all the work that you do and for always joining us on our webinars and for always saying yes, because it goes a long way and to help us understand these subjects and these what can be very complicated areas of Fabry, but you have a great way of being able to explain it. So thank you so much. If you have any questions at the bottom of Zoom, you'll just find the chat. If you want to put them in there or just text or message me, either one is okay, and we can talk about them. I did like how you explained the guest at the table. I thought that was a great analogy. Anybody have
Usually
any
it takes some
questions?
warming up to get the questions out, but once the first question comes, then they all kind of come after that.
That's right. Okay. Um, here is one. So someone was just asking about, someone was just asking about when, I think that you explained this a little bit, but maybe just a little bit more. When they do this therapy, previously they've had to have like chemo. In this therapy, you don't have to use that, right?
That's correct. Yeah, because we had to use chemo in the previous trials, which were the lentiviral trials, because we're putting the stem cells back, and the stem cells were only engraft, which means they'll take up positions in the bone marrow where they keep multiplying and making enzyme if there's room for them. So if we go back to the guest analogy, if there's 4 spots in the couch and a 5th person comes, somebody has to be kicked off for that 5th person to sit. And that's what the chemo does. With the AAV type therapies, because they're not going into stem cells, they're going mostly into liver cells, then we don't have to suppress the immune system with chemotherapy that way. But there are many trials where there is some suppression of the immune system with steroids or a drug called tacrolimus or sirolimus to allow the immune system not to destroy the vector that was given and for the vector to then get into the organ of interest. So it's not the same type of chemotherapy, but that doesn't mean there is no chemotherapy in AAV related studies, but it's usually not as strenuous as the ones in the lentiviral studies.
Thank you. Is it only Calgary doing the San Gambo trial?
Right now in Canada, it's the only site that's been activated, but I know there has been interest in other sites, so people in their centers can ask when it might be coming to their site.
Perfect. And a very good question. How does this affect my funding for my current therapy if I try this?
So in most situations, and it will vary depending on province, certainly in Alberta, if we did a gene therapy and it didn't work, then we would aim to put somebody back on their original treatment. So it can be hard to define when it hasn't worked though, because whether it's the lentiviral trials or the AAV trials, they do tend to increase enzyme production. And then it's hard to know when is enough sustainable or considered a response. So that part has been a bit challenging. Do you wait for a significant clinical event to occur? The issue though is Fabry is a progressive disease that none of these treatments will cure. Was the clinical event part of the natural history, or was it because of the failure of therapy? And those things become difficult decisions to try to come to a conclusion about. But I would check with your doctor to see how it would affect your current treatment in the province you are in, whether you go, if you go on to one of these trials.
Thank you. And why is the FACT study redosing said to be difficult while the ex vivo is not possible?
So now there's no redosing, of course, right now in either of those, but you'd have to go through another apheresis and chemo regimen to redose on a lentiviral trial. So I don't think it's been tried yet. It has also not been tried publicly, to my knowledge, with the AAV vectors, although technically if you suppress the immune system, you could redose, and people are thinking about that. But for Fabry disease, I don't think there's redosing in either of those two.
From Sandy, can you please explain again what the increased health benefits were from the participants of the trial?
Oh, so right now, I mean, as I described in the ST920 study, they did have a survey that looked at some health questionnaire questions. I don't have knowledge of the individual responses, of course. We didn't do that in the FACTS study. We never really had a questionnaire. We had such small numbers of patients that it wouldn't have been statistically possible to make meaning of it. We kind of report them what we call qualitatively, meaning how's the patient responding, how are they feeling. So it's hard to say, and you'd have to check with the patients individually whether they actually feel better. So we can't really say that people necessarily feel better from getting the gene therapy. They aren't subjected, if they go off ERT, to their enzyme infusions anymore. So that part has changed for some patients. I don't know that pain response has been better treated, and it's not a target right now to treat the pain response, because remember, this is going into the liver, it's going to make enzyme, and then the enzyme is going to float around and be taken up by other organs. So it's a kind of enzyme replacement therapy. But pain is a particular challenge in patients with Fabry disease in terms of response. So the main response in these trials usually has some variation of heart or kidney function.
Great, thank you. If anyone else has any more questions for Dr. Khan, feel free to put it in the chat below. And if not, you can always email us, and we can find a way to get the answer to you as well. So I think that's good, Dr. Khan. Thank you again so much for joining. And if anybody else wants to catch more of this online, feel free to at fabrycanada.com. And it's just under our webinar, so you can watch it again.
Thank you.
Okay, thank you very much, everyone, for joining. Thank you.
Bye-bye.
Have a great night.